Okay, so we continue the review of skeletal and soft tissue conditions. This time it's going to be on osteomalacia, one of the three metabolic disorders: osteoporosis, osteomalacia, and Paget's disease. Um, we'll start with the therapy ed PDF that Final Frontier provided. So, osteomalacia. It is characterized by decalcification of bones due to vitamin D deficiency. Symptoms include severe pain, fractures, weakness, and deformities. Medications include calcium, vitamin D injections in the form of calciferol, vitamin B2, D2. Diagnostic tests include plain films, lab tests such as a urinalysis and blood work, a bone scan, and a bone biopsy if warranted. Clinical examination assists in confirming diagnosis. Physical therapy goals, outcomes, and interventions include joint bone protection strategies, the goal to maintain or improve joint mechanics and connective tissue functions, and the implementation of an aerobic capacity endurance conditioning or reconditioning program such as aquatic therapy. So now we will go to the readings. My little
Osteomalacia definition in contrast to osteoporosis, which results in a loss of bone mass and brittle bones. Osteomalacia is a progressive disease in which lack of mineralization of the bone matrix results in a softening of bone without loss of the present bone matrix. Osteomalacia is a generalized bone condition in which insufficient mineralization of the bone matrix results from deficiency of calcium, vitamin D, and/or phosphate. The disease is sometimes referred to as the adult form of rickets, with the absence of epiphyseal plates in adults precluding the epiphyseal plate changes seen in rickets. Etiologic factors. The two primary causes of osteomalacia are insufficient intestinal calcium absorption and increased renal phosphorus losses. The insufficient calcium absorption occurs because of either a lack of calcium or a resistance to the action of vitamin D. Excessive levels of the fibroblast growth factor 23 will inhibit reabsorption of phosphate in the renal tubules. 42 increased renal phosphorus losses can also occur associated with renal osteodystrophy. See chronic renal failure in Chapter 18 and Figure 18.7, and renal tubular insufficiency. In addition, the long-term use of antacids, which contain aluminum hydroxide that bind with dietary forms of phosphate to prevent GI absorption, and the presence of long-standing hyperparathyroidism can lead to phosphate deficiencies, contributing to the development of osteomalacia. The dietary deficiency type of osteomalacia has been eradicated in the United States for the most part by the widespread supplementation of dairy products with vitamin D. However, osteomalacia does occur in the malnourished aging adult who may not receive adequate nutrition or enough exposure to sunlight. 127 incidence and risk factors. Osteomalacia is essentially a histologic diagnosis, so little information on its overall prevalence in the adult population is available. Diseases of the small intestine, cholestatic disorders of the liver, biliary obstruction, and chronic pancreatic insufficiency increase the risk of developing osteomalacia. These conditions adversely affect the absorption of calcium and the action of vitamin D. The incidence of osteomalacia is greater in the world's colder regions, which is related to decreased exposure to sunlight, affecting vitamin D levels. Osteomalacia is seen with greater frequency in cultures where the population has increased skin pigmentation and the diet is deficient in vitamin D. For example, northern China, Japan, and northern India. 31 Osteomalacia is common in the aged adult because of calcium and vitamin D deficient diets and decreased sunlight exposure. Housebound and institutionalized individuals are especially at risk. Thus, the prevalence of osteomalacia is expected to increase with the aging of the American population. 31 This situation is worsened by the intestinal malabsorption problems associated with aging or the presence of SLA that usually requires avoidance of sunlight to prevent ultraviolet-induced flare-ups. 128 long-term use of commonly prescribed medications also increases the risk of developing osteomalacia. Anticonvulsant medications, such as phenobarbital and phenytoin, accelerate breakdown of the active forms of vitamin D by inducing hepatic hydroxylases. As mentioned, antacids can cause phosphate deficiency. Box 24-6 summarizes the risk factors associated with osteomalacia. Pathogenesis. Osteomalacia develops from the lack of calcium salts depositing in the bony matrix, resulting in an increase in the extent of the uncalcified or osteoid matrix. The structure of the bone is unchanged, but is greatly weakened from the lack of mineralized content. The radiographic appearance of the osteomalacia is found in the textural changes of osteoid seams. The decalcification results in an exaggeration of the osteoid seams seen adjacent to the relatively sparse areas of calcified bone. Figure 24-6. These exaggerated seams occur because of the excessive time lag between collagen deposition and the appearance of the calcium salt. As the osteoid accumulates, bone strength declines. Areas of abundant osteoid appear as radiolucent stripes. These stripes are known as lusozones or pseudofractures and occur most commonly on the concave side of long bones, the ischial and pubis rami, and the ribs and scapula. Figure 24-7. Pseudofractures also develop from the healing of multiple microstress fractures in the moderately severe form of osteomalacia, sometimes referred to as milkman syndrome. 127 clinical manifestations. The diagnosis of osteomalacia is difficult and often delayed because many people present initially with diffuse, generalized aching and fatigue in the presence of anorexia and weight loss. Proximal myopathy and sensory polyneuropathy may also be present, resulting in a confusing clinical presentation. Bone pain and periarticular tenderness can occur in the spine, ribs, pelvis, and proximal extremities. The combination of muscle weakness and softening of bone contributes to postural deformities, including increased thoracic kyphosis, a heart-shaped pelvis, and marked bowing of the femurs and tibias. The muscular weakness, proximal myopathy, may lead to a waddling gait and difficulties with transitional movement, such as rising from sitting to standing, climbing stairs, or moving into and out of bed. Occasionally, the hypercalcemia associated with osteomalacia leads to latent tetany, with paresthesias of the hands and around the mouth, muscle cramps, and positive Chvostek intruso signs. See figures 5.8 and 5.9. Medical management. Diagnosis. Osteomalacia may present with a variety of clinical and radiographic signs mimicking other musculoskeletal disorders, for example, fibromyalgia or polymyalgia rheumatica. For this reason, numerous methods are used to diagnose osteomalacia, including radiographs, bone scan, bone biopsy, and a laboratory's workup. Blood serum levels of calcium, albumin, phosphate, alkaline phosphatase, and PTH are obtained, and urine is collected to assess calcium and phosphate excretion rates. 122 radiographically, osteomalacia, like osteoporosis, may appear as osteopenia. A bone biopsy at the site of osteopenia will evaluate the calcification levels of the bone matrix. Besides osteopenia, radiolucent bands in the bone cortex, lusozones, may be revealed radiographically. See figure 24-7. Although not occurring nearly as often as in osteoporosis, acute fracture may be what leads to the diagnosis of osteomalacia. The radius, femur, vertebral bodies, ribs, and pubis ramus are common sites of fracture. Treatment. The treatment of osteomalacia depends primarily on the cause. If inadequate nutrition is the problem, strengthening the dietary regimen with calcium and vitamin D is necessary. This step may be sufficient to improve the calcification of the organic matrix and thereby result in healing of the pseudofractures and strengthening the bones in general. If osteomalacia is a result of intestinal malabsorption, treatment is directed to correct the primary disease. Phosphate supplementation can be prescribed in the presence of renal phosphate wasting. If used, vitamin D must be given to enhance calcium absorption impaired by the phosphate. Special implications for the therapist. 24.2 Osteomalacia. See special implications for the therapist. 24.1 Osteoporosis above. Considerable overlap occurs between osteomalacia and osteoporosis regarding implications for the therapists. The reader is directed to the section associated with osteoporosis for the discussion of client injury during examination and intervention, recognition of possible fracture, post-operative care, and side effects of calcium agents. See Chapter 27 for a discussion of prevention of fracture.
Work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today.
Bone softening caused by a faulty process of bone mineralization manifests as either rickets in children or osteomalacia in adults. Inadequate bone mineralization could be due to a deficient or impaired metabolism of vitamin D, phosphate, or calcium. But first, a bit about bones. Now, long bones like the femur are made up of two epiphyses, which are its ends, and the diaphysis, which is the shaft. Between each epiphysis and the diaphysis, there is a region called the metaphysis, and the metaphysis contains the epiphyseal plate, or the growth plate, which is the part of the bone that grows during childhood. Once growth stops, the growth plate is replaced by an epiphyseal line, and this is known as epiphyseal closure. Now, for bones to grow and develop properly, special bone cells called osteoblasts are hard at work. To build bone, osteoblasts secrete osteoid, which is an organic matrix made up of type 1 collagen. These collagen fibers are the framework for the osteoblast's work. Osteoblasts then deposit calcium and phosphate crystals into the framework. This process is called bone mineralization, and it confers strength to the growing bones. Bone mineralization is dependent on an enzyme called alkaline phosphatase, which increases in response to osteoblast activity. So at the end of the day, bones are like a storage warehouse for calcium and phosphate. Now, the levels of calcium and phosphate in the bone, but also in the blood, are regulated by vitamin D and parathyroid hormone, or PTH. Vitamin D-wise, two steps are necessary for optimal metabolism. First, there must be enough vitamin D in the body, either from food or created in the skin in response to sunlight exposure. Secondly, vitamin D must become metabolically active, and this process also has two steps. First one happens in the liver, where inactive vitamin D is converted into 25-hydroxyvitamin D by the enzyme 25-hydroxylase. 25-hydroxyvitamin D then travels to the kidneys, where the enzyme 1-alpha-hydroxylase converts it to 125-hydroxyvitamin D, or calcitriol, which is the active form of vitamin D. Calcitriol increases renal tubular reabsorption of calcium, which reduces the loss of calcium in the urine. Calcitriol also increases the intestinal absorption of calcium and phosphate. Okay, now let's have a quick look at parathyroid hormone. Parathyroid hormone is secreted in response to low blood calcium levels, and it stimulates the resorption of calcium and a small amount of phosphate from the bone and into the bloodstream. Additionally, parathyroid hormone can boost 1-alpha-hydroxylase activity, which forms more active vitamin D, increasing gut absorption of calcium. Lastly, parathyroid hormone increases calcium reabsorption and reduces the reabsorption of phosphate from the kidneys, so more phosphate is excreted through the urine. Now, when there's not enough active vitamin D, calcium, or phosphate, there's inadequate mineralization. This means that osteoblasts don't have enough calcium and phosphate to deposit into the organic matrix. In children, because the growth plates haven't closed yet, this leads to softening of the bones, impaired growth of bones, and bone malformations. Whereas in adults, where the epiphyseal plates have already closed, it only causes weakening and softening of bones, which makes them easier to fracture. Okay, now vitamin D deficiency is the most common cause of both rickets and osteomalacia. Causes of vitamin D deficiency include intestinal malabsorption, which can be seen with celiac disease or Crohn's disease, not enough UV light exposure, like in homebound elderly populations. Medications like phenytoin, an anticonvulsant, uses liver and kidney hydroxylase enzymes for its own metabolism, so especially with long-term use, there's not enough vitamin D being generated. And finally, there's liver and kidney disease. For example, rickets or osteomalacia can occur in chronic liver disease due to the liver's inability to turn inactive vitamin D into 25-hydroxyvitamin D. The same goes for chronic kidney disease, where the kidneys can't turn 25-hydroxyvitamin D into 125-hydroxyvitamin D. Both conditions result in an active vitamin D deficiency, which leads to impaired bone mineralization. With both rickets and osteomalacia, symptoms include diffuse bone and joint pain, proximal muscle weakness, bone fragility, and increased risk of fractures with minimal trauma. Because of low levels of calcium, there may also be muscle spasms and numbness. Rickets-specific symptoms include thin, soft skull bones, which is called craniotabes, delay in the closure of fontanelles, and bow legs, also known as genu varum. There may also be an enlarged prominent frontal bone and with severe disease a protruding abdomen. Additionally, a ricketic rosary may be seen. This is when little bumps appear along the chest due to the widening of the junction between the ribs and the costal cartilage in front of the rib cage. Rickets and osteomalacia are usually diagnosed with lab tests, which show abnormally low vitamin D levels in blood serum, low blood calcium, and elevated serum alkaline phosphatase. As a result of low calcium, there may also be high PTH, which may also lead to low serum phosphate. Now, X-ray imaging of rickets and osteomalacia might show signs of decreased bone mineral density or osteopenia. First, there's looser zones, which are bands of low bone density that form on the surface of the bone. And they look a bit like bone fractures, so they're also called pseudofractures. Looser zones frequently develop in the inferior and superior pubic rami of the pelvic bone. In rickets, an X-ray image of the wrist and long bone metaphyses might demonstrate metaphyseal cupping and flaring. With metaphyseal cupping, the edges of the metaphysis widen laterally, like flared jeans, and the metaphysis itself drops inwards towards the diaphysis, which makes it look a bit like a cup. Another X-ray finding in rickets is metaphyseal fraying. Instead of the metaphyseal surface appearing smooth, it appears fuzzy and irregular. Finally, another X-ray finding with rickets may be bowing of the legs. Treatment for both rickets and osteomalacia typically involves oral vitamin D supplementation and treating the underlying cause, which could be any condition affecting the organs responsible for vitamin D activation. In addition, preventative measures include vitamin D supplementation during pregnancy and administering vitamin D drops to neonates and infants. Alright, as a quick recap, rickets and osteomalacia are conditions in which bone softening occurs due to a mineral deficiency or lack of vitamin D. Now, rickets presents in children, and osteomalacia happens in adults, which depends if there was growth plate closure. Some key symptoms of rickets are craniotabes and bow legs. For osteomalacia and rickets, the key symptoms are diffuse bone and joint pain, proximal muscle weakness, bone fragility, and increased risk of fractures with minimal trauma. There may also be looser zones on X-rays. The treatment typically involves oral vitamin D supplementation and treating the underlying cause.
Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon.
Okay, since that was only about 20 minutes of material, we're going to go ahead and add osteoporosis to this video. It's again one of the 3 metabolic disorders shown on this picture right here from the pathology book. So again, this is the Therapy Ed PDF, part of the Therapy Ed PDF that was supplied by Final Frontier. Skeletal and soft tissue conditions. Number 1, osteoporosis, a metabolic disease that depletes bone mineral density mass, predisposing individual to fracture. Affects women 10 times more frequently than men. Common sites of fracture include thoracic and lumbar spine, femoral neck, proximal humerus, proximal tibia, pelvis, and distal radius. Primary or postmenopausal osteoporosis is directly related to a decrease in estrogen production. A decrease in estrogen production. Senile osteoporosis occurs due to a decrease in bone cell activity secondary to genetics or acquired abnormalities. Medications include calcium, vitamin D, estrogen, calcitonin, and biphosphonates. Diagnostic tests utilized include a CT scan to assess bone density, single and dual photon absorptiometry are also used but very expensive. Clinical examination will assist in confirming diagnosis. Physical therapy goals, outcomes, and interventions include joint bone protection strategies, maintain improved joint mechanics and connective tissue functions, implementation of aerobic capacity, endurance conditioning, or reconditioning, such as aquatic programs, patient-client education on dietary changes to improve mineral intake. Okay, so, I didn't get it up here. Let's see, let's just go back here and look at the PowerPoint and see what page that was on. 1211. Yeah, and there we are, right there. Okay.
Osteoporosis definition and overview. Osteoporosis is a chronic, progressive disease characterized by low bone mass, impaired bone quality, decreased bone strength, and enhanced risk of fractures. 98 Osteoporosis can be classified as primary or secondary, depending on the underlying etiology. Primary osteoporosis, the most common, can occur in both genders at all ages but often follows menopause in women, and occurs later in life in men. Osteoporosis associated with medications, other conditions, or diseases is referred to as secondary osteoporosis, box 24(1). Incidence osteoporosis is by far the most common metabolic bone disease, affecting more than 10 million people living in the United States. An additional 34 million Americans already have low bone mass, osteopenia, that places them at increased risk of osteoporosis. With the aging of America, osteoporosis is expected to increase in prevalence. 16 The disease is much more common in women, especially postmenopausal women who are estrogen deficient. However, osteoporosis in men represents a major public health problem, which until recently has received little recognition. Approximately 2 million men are affected by osteoporosis and another 12 million are at risk as a result of low bone mass. This condition in men remains underdiagnosed, undertreated, and underreported. 34, 36. 101 in every 2 women older than 50 years of age will experience fragility fractures secondary to osteoporosis. 44 1 in 4 men will experience an osteoporosis-related fragility fracture during their lifetime, usually later, because of greater bone mass than women, at approximately age 70 years. When affected, men have a higher morbidity and mortality than that of women, 30% versus 9%. 0.12, 147. This is because men are older at the time they sustain a fracture and are more likely to have comorbid disease, malnutrition, and complicated hospitalizations. 149 etiologic factors. The cause of primary osteoporosis is unknown, but many contributory factors exist such as mild but prolonged negative calcium balance, declining gonadal and adrenal function, relative or progressive estrogen deficiency, or sedentary lifestyle. Secondary osteoporosis may be caused by prolonged therapy with corticosteroids, heparin, anticonvulsants, and other medications, alcoholism, malnutrition, malabsorption, or lactose intolerance, endocrine disorders, or other conditions or diseases. See box 24.1. Risk factors between the ages of 25 and 35 years. Bone mass peaks, and the rate of bone resorption begins to exceed the rate of bone formation. This physiologic mismatch can progress to a point at which osteopenia, box 24.2, may be noted radiographically and a progression of osteoporosis is suspected. Box 24.1 lists the many risk factors and conditions or diseases associated with osteoporosis. Chronic diseases, or medications used to treat these diseases, may have side effects that can damage bone or interfere with bone formation, leading to osteoporosis. A difference is certainly evident between risk factors for osteoporosis and risk factors for fractures. See box 27.16. Estrogen status, heredity, and ethnicity are important risk factors for osteoporosis in women. Alcoholism, cigarette smoking, steroid therapy, and hypogonadism or androgen withdrawal therapy for prostate cancer are the most common factors for men. 171. Although in 50% of cases, a cause is unknown, 147. Age is a risk factor for both men and women. The 10-year fracture risk at age 50 is quadruples by age 80 years. Although women are affected earlier in the decades compared to men, the associated mortality and morbidity is much greater for men. 1. Hormonal status. Postmenopausal women are at higher risk to develop the disease. Diagnosis of primary postmenopausal osteoporosis occurs with increasing frequency from age 51 to 75 years. The increased risk of osteoporosis related to menopause is due primarily to the decreased production of estrogen. Estrogen deficiency is linked mostly to the loss of cortical bone, which is linked to the increased risk for fractures. 71. Decreased intestinal calcium absorption, increased bone resorption to compensate for low calcium levels, and impaired osteoblastic activity have all been associated with estrogen deficiency. Women lose bone at the usual rate of 1% per year after peak bone density has been achieved. However, bone loss accelerates to a varying degree, depending on such factors as calcium intake and absorption, hormonal balance, and activity level, for about 5 to 8 years after menopause, increasing the risk of fracture. Researchers report a wide range from 2% to 11% loss for the 10 years after menopause, slowing after that to about 0.5% to 1% of bone mass per year. Men experience a gradual slowing of testosterone production with age, and below normal testosterone levels have been associated with loss of bone mineral mass. The outward signs of this phenomenon, for example, loss of muscle strength, fatigue, and decreased interest in sex, are often attributed to aging without considering the accompanying osteoporosis that ensues. Other risk factors include androgen deprivation, treatment for prostate cancer, and hypogonadism associated with erectile dysfunction. 15. Low serum testosterone levels have also been documented in men treated with corticosteroids for chronic inflammatory conditions such as sarcoidosis. 2. Heredity genetics. Peak bone mass is partly genetically determined as evidenced by the varying prevalence of osteoporosis among different ethnic groups, but other variables also exist such as differences in bone geometry and rate of bone loss. Individual differences among people of the same ethnic background can occur, possibly in part because of inheriting specific genes that affect bone mass and turnover. 128 8 genes have been linked to bone density with a strong connection to the receptor for parathyroid hormone, PTH1. This hormone plays a crucial role in determining the level of calcium in the blood. Genetic differences in the levels of receptors for PTH in the blood may determine bone density. The results of some research suggest that gender specificity as to how these genes are expressed plays a key role. That is, men and women may inherit these genes differently. 0.35 Body build is related to bone fragility. Older women who weigh less than 127 pounds tend to have less cortical bone and are therefore at greater risk of fractures. Obesity, by increasing the mechanical strain on the bone, may result in increased peak bone mass, reducing bone fragility. In addition, obesity increases the amount of biologically available estrogen, protecting against fracture. Women with a family history of osteoporosis are at high risk of developing osteoporotic fractures. 130 ethnicity. Ethnicity is also considered a risk factor because bone mass correlates positively with skin pigmentation. Whites have the least amount of bone mass, whereas blacks have the greatest amount. Men have wider long bones than women, and blacks have wider long bones than whites. Therefore, black men are at lowest risk of developing osteoporosis, 135, because white women generally have lower peak bone mass. The complications of the bone loss associated with aging can affect them earlier in life. Limited information available suggests that Native American women have lower bone densities than white non-Hispanic women, and Mexican American women have bone densities intermediate between those of white non-Hispanic women and black women. 91. On the other hand, skin pigmentation also correlates with vitamin D synthesis, with more heavily pigmented people requiring greater amounts of sunshine to synthesize vitamin D needed for bone strength. Early reports indicate that osteoporosis may be more prevalent in Hispanic, Native American, Asian, and black women than once thought. Physical inactivity, and immobilization have been associated with decreased bone formation. The prolonged inactivity results in reduced gravitational and muscular forces acting on the skeletal system. The decreased mechanical stress on bony structures alters bone physiology, resulting in decreased bone mass. Disuse osteopenia, which can be caused by immobilization, for example, cast, bed rests, long-term care, or neurologic impairment, results from a change in cellular function or an increase in the recruitment of osteoclasts. The difference in the quality of bone produced is in the decreased number of trabeculae and in increased osteoclastic performance. Residents in nursing home or long-term care facilities have a 5 to 10-fold greater fracture risk than community dwellers. 37. Tobacco. Cigarette smoking is associated with a reduction of bone mass and is a well-known risk factor for spinal and hip fractures. The effects of smokeless tobacco and secondhand smoke have not been evaluated as risk factors but may be important considerations. Some evidence suggests that cigarette smoke may affect bone progenitor cells by directly contributing to the development of osteoporosis. 32. 77. 145. Alcohol. More than 2 units of alcohol per day is a risk factor for osteoporosis. 66. A unit is defined as 112 oz beer, 1/5 oz glass of wine, or 1.5 ounces of hard liquor. Excessive alcohol intake alters osteoblast gene expression and matrix synthesis, thereby reducing the number of effective cells. 168. Chronic alcohol use can impair intestinal absorption and increase renal excretion of calcium, contribute to poorer overall nutrition, and increase the likelihood of a fall. In men, consuming large amounts of alcohol is a major independent risk factor for hip fractures. 55. Combined alcohol and corticosteroid use has a significant impact on the development of osteoporosis. 90. See tobacco and depressants in Chapter 2. Medications. Long-term use of medications, including corticosteroids, has been associated with the presence of osteoporosis. People with a wide range of medical conditions, for example, asthma, chronic obstructive pulmonary disease, COPD, organ transplantation, renal impairment, arthritis, systemic lupus erythematosus, SLE, Crohn's disease or regional enteritis, sarcoidosis, and others, may be taking corticosteroids. Most bone loss occurs during the first 6 months of systemic corticosteroid therapy. Loss of 10% to 15% of spinal trabecular bone mass is possible. After that, bone loss averages 1% to 2% annually. Corticosteroids impair osteoblastic activity and the maturation of preosteoblastic cells to osteoblasts, increase osteoclastic activity, and impair vitamin D-dependent intestinal calcium absorption, which can result in secondary hyperparathyroidism. The hyperparathyroidism increases bone resorption and decreases renal resorption of calcium, thereby increasing the amount of calcium excretion. Other medications have also been implicated. See box 24.1. Selective serotonin reuptake inhibitors, SSRIs, are not on this list, but there is some preliminary evidence that links the use of SSRIs to the increased risk of fracture for those older than age 50 years. 124. 132. More research is needed to identify if depression itself is the source of endocrine changes that can damage bone. 52. Depression. Depression is now recognized as a risk factor for osteoporosis. 133. 174. Individuals with a history of a major depressive disorder are more likely to have lower bone densities and higher levels of cortisol than people without depression, regardless of physical activity levels. Major depressive disorders are thought to cause bone loss primarily due to immune and endocrine mechanisms. Depressive disorders are also associated with poor lifestyle habits that are potential contributory factors to bone loss. 21. Depression may be a risk factor in other ways. A study of bone loss in premenopausal women with and without major depression showed that those who were depressed had unfavorable levels of cytokines that specifically affect bone mass. 21. Cytokines act as chemical messengers between the immune, nervous, and endocrine systems. 86. Diet and nutrition. Different sources of dietary protein may have different effects on bone metabolism. Women age 65 and older with a high dietary ratio of animal to vegetable protein intake have more rapid femoral neck bone loss and a greater risk of hip fracture than do those with a low ratio. Animal foods provide predominantly acid precursors, whereas protein in vegetable foods is accompanied by base precursors not found in animal foods. Imbalance between dietary acid and base precursors leads to a chronic net dietary acid load that may have adverse consequences on the bone. 134,136. Excess acid is excreted in the urine, but with aging, the kidneys are less capable of excreting acid. Bone density is decreased in anorexic and bulimic women and is possibly the result of estrogen deficiency, low intake of nutrients, low body weight, early onset and long duration of amenorrhea, low calcium intake, reduced physical activity, and hypercortisolism. This type of reduced bone density is associated with a significantly increased risk of fracture even at a young age. 46. The female athlete triad describes the combination of disordered eating, amenorrhea, and osteoporosis, which is a situation that often goes unrecognized and untreated. 101,154. A significant number of people with osteoporosis also have celiac disease, a gastrointestinal, GI, disorder that impairs the absorption of calcium, various nutrients, and vitamin D needed for maintaining healthy bones. Identification and effective dietary therapy for celiac disease can lead to improved absorption of vital nutrients and potentially reverse the decline in bone mineral density, BMD. Celiac disease increases the long-term risk of fracture, especially hip fracture. 54. 80. New information about the role of cholesterol in bone health has come to light. High cholesterol associated with a high-fat diet may decrease overall bone production through the process of oxidation. Oxidative stress modulates differentiation of vascular and bone cells oppositely so that a parallel buildup and loss of calcification occur in vascular calcification and osteoporosis, respectively. 94. Preliminary studies in animals suggest that an atherogenic diet inhibits bone formation by blocking differentiation of osteoblast progenitor cells. 111. 112. Pathogenesis. Bone is composed of a meshwork of collagen fibers inlaid with calcium and phosphate. These minerals are mixed with water to form a hard, cement-like substance called hydroxyapatite. Sodium, magnesium, and potassium are also present in smaller amounts. The human skeleton is composed of two main bone types, trabecular and cortical. Bone strength is made up of two components, bone density and bone quality. Bone density refers to how many bone cells are present in a square inch. That measure also reflects how close together the bone cells are. But density isn't the only component of bone strength. There is also bone quality. Bone quality reflects the health of the bone cells present, quality of the collagen cells that make up bone, thickness of the bone, and architecture of the bone all make up this entity we call bone quality. Bone quality reflects the condition of the supportive structure of bone. BMD increases during growth and development, and the peak bone mass is achieved in the third decade of life. This is the bone bank for the rest of a person's life. 19. An individual with a high peak bone mass who starts to lose bone later in life and loses it slowly is unlikely to sustain osteoporotic fractures, whereas someone with suboptimal peak bone mass who starts to lose bone earlier in life or loses bone rapidly is more likely to develop osteoporosis with fractures. Osteoporosis develops when new bone formation falls behind resorption, possibly related to impaired new bone formation due to declining osteoblast function. Figure 24.1, Figure 24.2. The onset of bone loss is likely to be genetically predetermined, and the subsequent rate of bone loss may also be influenced by genetic factors. Bone loss increases at the time of menopause as a result of the marked reduction in the circulating concentrations of estradiol and progesterone. Figure 24 3.41. Other causes of age-related bone loss have been discussed previously in this chapter. Each one of those contributing factors has its own pathologic process. Only the general pathogenic concepts are discussed here. Small defects in formation remaining at the completion of a normal remodeling cycle accumulate and also contribute to age-related losses in bone mass. Thus, the bone that experiences the greatest number of remodeling cycles is at the highest risk for age-related losses in mass. New information about metabolic bone diseases has revealed that maintenance of adult skeletal mass is controlled not only by changes in the production of osteoclasts and osteoblasts but also by altering the duration of their respective life. Spans through regulated apoptosis, programmed cell death, during bone remodeling, disruption of the rate of supply of new osteoblasts and osteoclasts, and the timing of the supply by apoptosis may be an important mechanism behind the deranged bone turnover found in most metabolic disorders of the adult skeleton. 63. 166 defects in a protein called alpha-beta-3 integrin appear to play a role in the development of osteoporosis. The effects of this protein can be reversed by enhancing another protein, macrophage colony stimulating factor, MCSF. The interaction between MCSF and alpha-beta-3 integrin is under investigation. These proteins may have a role in bone cell differentiation and the signaling pathway that causes a change in osteoclast and osteoblast balance. 151,152,175 Bone demineralization, which can lead to osteopenia, takes place when a deficit in hormone levels, inadequate physical activity, mechanical load, or poor nutrition occurs. Bone strength is a function of skeletal load, that is, bone responds to alterations in mechanical forces. Although the exact physiologic mechanism causing bone to sense and respond to alterations in mechanical loads is unclear, adaptations appear to be site-specific. Mechanical stimuli may be the only type of stimuli capable of inducing modeling in mature bone. Young bone responds more favorably to mechanical loading than old bone, again emphasizing the importance of physical activity and exercise in the adolescent and young adult. 163 Physical activity transmits mechanical loads to the skeleton through gravitational forces and muscular pull at sites of attachment. In the absence of mechanical forces, spaceflight or prolonged bed rests, urinary calcium excretion increases and bone density decreases. BMD changes induced by loading are not maintained long-term, which is why regular site-specific and weight-bearing exercises must be done routinely to prevent osteoporosis and reduce bone fracture risk. 163 Subsequently, hormone levels, physical activity, and nutrition are the key factors that facilitate bone growth because they regulate the osteoblastic and osteoclastic remodeling cycles, initiate a natural cycle of microscopic bone damage and subsequent repair, and foster solid bone architecture. 113 Gender differences. Studies of normal age-related changes in human bone have been investigated by using a combination of different techniques. Men show an age-related compensatory increase in bone size, cross-sectional area of the vertebral bodies, which cannot be found in women. Women have a higher tendency, after age 50 years, to demonstrate disconnection of the trabecular network that can be positively affected by physiologic loading such as occurs during exercise. 95 Clinical manifestations. Loss of height, postural changes, back pain, and fracture are the most common presenting features of osteoporosis. Postural changes may include lax abdominal musculature, protuberant abdomen, forward head, kyphosis, dowager's hump, loss of lumbar lordosis, posterior pelvic tilt, knee hyperextension, shoulder internal rotation, scapular forward rotation, palms facing backward, and other deviations in alignment observed when assessed by a physical therapist. Marked thoracic spine kyphosis and loss of overall body height are common findings, especially after a vertebral compression fracture. 68 Similarly, bone loss in the mandible can contribute to changes in facial appearance. Muscular pain and spasm can occur in the lower back paravertebral muscles, as can burning pain in the mid-thoracic region lateral to the spine because of excess stretch placed on the rhomboid muscles from the compensatory forward rotation of the scapulae. Trigger points secondary to kyphoscoliosis, rhomboid imbalance, and paravertebral muscle spasm are common. Similar muscle imbalance and muscular symptoms are observed or reported in the lower quadrant with involvement of the lumbosacral and sacroiliac joints and surrounding musculature. 64 fractures. The vertebral bodies, hip, ribs, radius, and femur are the most common fracture sites, in that order. Although any bone in the body can be affected, a first fracture is a risk factor for a second fracture, which, in turn, increases the risk of death. 11 fractures are often silent compression fractures of vertebral bodies, sacral insufficiency fractures, or complete fractures of the spine or femoral neck. Metatarsal insufficiency fracture in both men and women may be an unrecognized early sign of osteoporosis. 155 vertebral compression fractures, VCFs, are the most common osteoporosis-related spinal fractures presenting with clinical symptoms of back pain, posture change, loss of height, functional impairment, disability, and diminished quality of life. Figure 24.4. These can occur without injury or fall when the bone becomes so porous or weakened it begins to compress. See fractures in Chapter 27. By age 90 years, the force required to produce failure of the L3 vertebrae is approximately 1/4 the compressive failure force at age 30 years. 69. The prevalence of vertebral fractures increases steadily with age, ranging between 20% for 50-year-old postmenopausal women and 64% for older women. The majority of vertebral fractures are not connected with severe trauma, and only 1 in 3 is diagnosed clinically. Almost 20% of women will experience another fracture within 1 year after a vertebral fracture. 48. Pain associated with VCFs is usually severe and localized to the site of fracture, typically mid-thoracic, lower thoracic, and lumbar spine. Tenderness to palpation over the fracture is common in both symptomatic and otherwise asymptomatic cases. Pain may radiate to the abdomen or flanks and is aggravated by prolonged sitting or standing, bending, or performing a Valsalva maneuver. Side lying with hips and knees flexed may alleviate the pain. Generalized bone pain is more suggestive of metastatic carcinoma or osteomalacia. Neurologic symptoms may not occur immediately but rather develop insidiously over days to months. 103. Medical management prevention. Since no cure is available for osteoporosis, prevention and, more effectively, early intervention is essential for everyone: men, women, young, and old, but especially for those at risk. Box 24.3. By minimizing modifiable risk factors, people at high risk for developing osteoporosis may be able to achieve higher peak bone mass in the hope of delaying or preventing the onset of osteoporosis. 98. Because peak adult bone density depends on factors during growth and development, preventing osteoporosis in the aging adult begins by providing necessary dietary calcium intake during bone development and calcification in childhood and adolescence. Table 24.1. A recent longitudinal study has determined that maternal consumption of magnesium, fat, and milk during the 3rd trimester of pregnancy will greatly influence an adolescent's bone mineral density. This study suggests that a child's in utero diet will affect the programming of bone responses. 173 other studies to assess the influence of maternal milk and soft drink consumption on children's consumption show that parents play a powerful role in children's eating behavior. They influence children's developing preferences and eating behaviors by making some foods available rather than others, and by acting as models of eating behavior. 40. 129. Serum screening for celiac disease in anyone with osteopenia or osteoporosis is advised because dietary changes can restore normal absorption of dietary nutrients in this group, including calcium and vitamin D, contributing to a reversal in the decline of BMD associated with osteoporosis. 146. Calcium. Peak bone mass is attained around age 30 years, at which time the pattern of bone building and bone loss is reversed, with more calcium loss than deposit. Regular exercise and physical activity, combined with adequate calcium, is considered both a prophylactic and treatment measure for osteoporosis from childhood through the adult years. The risk of fractures can be reduced by 50% if vitamin and nutrient requirements are met in the first 2 to 3 decades of life. 53. Low-fat dairy and other calcium and magnesium-rich foods, for example, broccoli or kale, sardines or salmon with the bones, fresh or dried apricots, figs, turnip greens, oranges or calcium-enriched orange juice, or tofu, and calcium supplements are the primary means of achieving an adequate calcium intake. 18. Vitamin D. Vitamin D helps the body absorb, synthesize, and transport calcium within the body, therefore necessitating adequate sunshine each day. Vitamin D requirements vary by geographic location and age. In northern areas, above the 42-degree latitude parallel, in the United States, imagine a line stretching from the California-Oregon border to Boston. The sunlight in winter angles too obliquely to produce the ultraviolet light needed for adequate vitamin D production. Additional vitamin D, food or supplementation, is recommended. Many calcium supplements contain vitamin D diet. Dietary considerations, such as reducing animal sources of protein, increasing vegetable sources, 134,136, and increasing whole soy foods, 131, may result in reduced risk for both cardiovascular disease and osteoporosis. Soybeans and foods made from soy high in phytoestrogens, which are plant chemicals classified as isoflavones that display estrogen-like activity because of their structural similarity to human estrogens. These substances exhibit high affinity binding for the estrogen receptor and may have a beneficial influence in the prevention of osteoporosis, cardiovascular disease, and endocrine-controlled cancer, for example, breast, prostate. This claim remains highly controversial. 22. According to some reports, the lipid-lowering oral statins, HMG-CoA reductase inhibitors, see Table 12.5, increase BMD by enhancing bone morphogenetic protein 2, BMP2, a powerful stimulator of osteoblast differentiation and osteoblastic expression, thereby promoting mineralization while reducing the risk of fractures. However, further testing is necessary before more specific recommendations can be made. 62,148 individuals with high risk for developing osteoporosis should consider a combination of dietary modifications and supplements. For women, baseline BMD test performed at the time of menopause, cessation of menstrual flow, or even earlier, during the perimenopausal phase, can provide a baseline assessment for future reference. Falls prevention, as a means of fracture prevention, is a separate component of osteoporosis management but not necessarily osteoporosis prevention. See falls preventions in Chapter 27. Screening. Whereas osteoporosis was once called a silent disease because it was not recognized until a fracture signaled its presence, the widespread availability of technology to measure bone density has made it possible to identify people at risk for osteoporosis before fractures are imminent. The NOF recommends that all men and postmenopausal women age 50 and older should be assessed for their risk of osteoporosis and related fractures. A BMD test is recommended in all women at age 65 and older and men age 70 and older. For men and women ages 50 to 69, a BMD test is recommended for those with high-risk factors or who have had a recent fracture. 98 Until evidence supports the cost, effectiveness of routine screening or the efficacy of early initiation of preventive drugs, an individualized approach has been recommended. 115 However, even given this guideline, appropriate screening is not taking place. According to at least one study of Medicare recipients, bone density testing was the lowest for women in the highest fracture risk group based on age. This may occur because physicians do not realize the benefit of screening and intervention in fracture prevention for older adults. 102 There is accumulating evidence that more and more younger adults are developing osteoporosis at an earlier age, ages 50-70, suggesting that baseline screening should begin even earlier. Therapists treating anyone with fragility fractures, vertebral compression fractures, or fractures anywhere in a postmenopausal woman should advise these individuals to ask their physician about medical screening for osteoporosis, including dual energy X-ray absorptiometry, previously DEXA, now DXA, scans and blood tests for metabolic bone markers, for example, vitamin D, calcium, parathyroid hormone. 0.33 Screening is particularly important for men at risk because fragility fractures are more likely to lead to fatal consequences than in women. Without a diagnosis of osteoporosis, treatment interventions that can prevent fractures are not initiated. 2. Diagnosis. Careful assessment of the osteoporotic person is essential in developing a comprehensive plan that reduces fracture risk and improves quality of life. Assessment of the individual with osteoporosis includes history and physical examination, laboratories testing, and imaging studies. Information gathered during this assessment assists clinicians in targeting strategies to prevent fractures. Diagnosis and intervention are based on bone density and risk assessment 140. In the case of secondary osteoporosis, the specific underlying cause must be determined through the diagnostic process before intervention can be initiated. History. The medical history should contain the personal and family history of fractures, lifestyle, intake of substances such as vitamin D, calcium, corticosteroids, and other medications. Clinicians should be aware of problems with vitamin D measurement, including seasonal variation, variability among laboratories, and the desirable therapeutic range. The physical examination can reveal relevant information such as height loss and risk of falls. 75 Bone mineral density testing. A BMD test is the simplest way to assess for osteoporosis. Without this test, most people are unaware they have osteoporosis until a fracture occurs, although some fractures can be painless or the pain may be mistaken for arthritis, delaying diagnosis. BMD is a measurement of the mineral content of bone in grams per square centimeter, GCM2, for the area of the body that has been scanned. A person's BMD measurement is compared to norm values of those of the same age and sex, called a Z-score, or can be compared to young adults of the same sex, T-score. A decrease in BMD will be reported in the absolute. Measure of bone in grams per square centimeter or in standard deviations below the average bone mass density. The WHO has developed a diagnostic classification system for postmenopausal women based on their BMD compared to the mean bone density of a young adult. A normal level is a BMD within one standard deviation of young adult, T-score at 1.0 or above. The osteopenia level is a BMD between 1.0 and 2.5 standard deviations below a young adult, and osteoporosis being a BMD is 2.5 standard deviations or more below a young adult. For premenopausal women and men under age 50, a Z-score adjusted for ethnicity of 2.0 standard deviations below the mean along with an assessment of their risk factors are used to make the diagnosis of osteoporosis. 98. 108 multiple imaging modalities can be used to evaluate BMD and diagnose osteoporosis, including DXA, which measures spine, hip, or total body density, peripheral DXA, DXR, which measures wrists, heel, or finger density only, quantitative ultrasound, QUAS, in which sound waves are used to measure calcaneal, tibial, or patellar density, peripheral computed tomography, PCT, or radiographic absorptiometry, RA, which is a radiograph of the hand. These methods are not interchangeable and do not provide equivalent information. DXA is the preferred procedure because it measures bone density at the femoral neck and lumbar vertebral bodies where bone loss occurs more rapidly. Table 24.2. DXA has the highest sensitivity and specificity, but sensitivity may not be adequate. The World Health Organization, WHO, recommends combining BMD to predict fracture risk with clinical risk factors. 140 DXA best predicts fracture risk in adults without previous fracture. BMD testing is most efficient in women over 65 years of age but is also helpful for men and women with risk factors. Serial BMD tests can identify individuals losing bone mass, but clinicians should be aware of what constitutes a significant change. 75 Predicting fracture risk. The World Health Organization has developed a computerized tool called the Fracture Risk Assessment of FRAX to calculate the 10-year risk of sustaining a fracture. 98. 170 It is based on individual patient models that integrate the risks associated with clinical risk factors as well as BMD at the femoral neck. Medication treatment is recommended for postmenopausal women and men age 50 or older who have a 3% to 10% risk of a hip fracture or 20% risk of major fracture elsewhere in the body, for example, wrists, spine, upper arm. According to the tests, radiographs, fractures are usually diagnosed by radiograph examination, X-ray, that demonstrates the fracture, figure 24.5, and also reveals the signs of osteopenia leading to the diagnosis of osteoporosis. Once osteopenia is noted, other causes of metabolic bone disease must be ruled out, including hypothyroidism, hyperparathyroidism, osteomalacia, testicular failure, malignancies, and so on. Histologically, a thinning of cortical bone and a reduction in the number and size of the trabeculae of cancellous bone occurs. See Figure 24.1. 30% or greater bone density loss must occur before such abnormalities can be noted on a radiographic film. Laboratories testing. Laboratories testing can detect other risk factors and can provide clues to etiology. Selection of laboratories tests should be individualized because there is no consensus regarding which tests are optimal. Biochemical markers of bone turnover, for example, alkaline phosphatase, osteocalcin, urinary hydroxyproline, urinary deoxypyridinoline, urinary N-telepeptide, and others, reflect the rate of bone remodeling and may be helpful in assessing for fracture risk and for effectiveness of the treatment regimen but are not widely used at present. 75 levels of serum total testosterone may be obtained for men. 108 treatment. Osteoporosis is not curable, but intervention can stop the progression of bone loss and prevent further morbidity. Secondary osteoporosis intervention begins with treatment of the underlying cause. Management of primary and secondary osteoporosis in the adult should include lifestyle measures to reduce bone loss such as a high calcium intake, smoking cessation, reducing alcohol intake, and physical activity and exercise. Besides eliminating factors such as chronic alcohol abuse and cigarette smoking, a key to prevention is developing as great a peak bone mass as possible through adequate calcium intake and regular exercise. Calcium is required for bone mineralization and also suppresses bone turnover, slowing the remodeling process. Fall prevention is an important intervention for anyone with low bone mass and high risk factors. Reports suggest that premenopausal women need more than 1,000 milligrams of calcium daily, and postmenopausal women need more than 1,500 milligrams daily. See Table 24.1. The average calcium intake of postmenopausal women is 400 to 500 mgd, well below the recommended levels. Vitamin D, 800 units D, is advocated to assist in maximal absorption of dietary calcium. 105 medications. Pharmacotherapy to reduce fracture risk in women with reduced VMD is initiated when the T-score is below 2.0 in the absence of risk factors or below 1.5 if other risk factors are present. 98. 105 AT score is not the only measure of fracture risk. A 70-year-old demonstrates the fracture, Figure 24.5, and also reveals the signs of osteopenia leading to the diagnosis of osteoporosis. Once osteopenia is noted, other causes of metabolic bone disease must be ruled out, including hypothyroidism, hyperparathyroidism, osteomalacia, testicular failure, malignancies, and so on. Histologically, a thinning of cortical bone and a reduction in the number and size of the trabeculae of cancellous bone occurs. See Figure 24.1. 30% or greater bone density loss must occur before such abnormalities can be noted on a radiographic film. Laboratories testing. Laboratories testing can detect other risk factors and can provide clues to etiology. Selection of laboratories tests should be individualized because there is no consensus regarding which tests are optimal. Biochemical markers of bone turnover, for example, alkaline phosphatase, osteocalcin, urinary hydroxyproline, urinary deoxypyridinoline, urinary N-telepeptide, and others, reflect the rate of bone remodeling and may be helpful in assessing for fracture risk and for effectiveness of the treatment regimen but are not widely used at present. 75 levels of serum total testosterone may be obtained for men. 108 treatment. Osteoporosis is not curable, but intervention can stop the progression of bone loss and prevent further morbidity. Secondary osteoporosis intervention begins with treatment of the underlying cause. Management of primary and secondary osteoporosis in the adult should include lifestyle measures to reduce bone loss such as a high calcium intake, smoking cessation, reducing alcohol intake, and physical activity and exercise. Besides eliminating factors such as chronic alcohol abuse and cigarette smoking, a key to prevention is developing as great a peak bone mass as possible through adequate calcium intake and regular exercise. Calcium is required for bone mineralization and also suppresses bone turnover, slowing the remodeling process. Fall prevention is an important intervention for anyone with low bone mass and high risk factors. Reports suggest that premenopausal women need more than 1,000 milligrams of calcium daily, and postmenopausal women need more than 1,500 milligrams daily. See Table 24.1. The average calcium intake of postmenopausal women is 400 to 500 mgd, well below the recommended levels. Vitamin D, 800 units D, is advocated to assist in maximal absorption of dietary calcium. 105 medications. Pharmacotherapy to reduce fracture risk in women with reduced BMD is initiated when the T-score is below 2.0 in the absence of risk factors or below 1.5 if other risk factors are present. 98. 105 T-score is not the only measure of fracture risk. A 70-year-old demonstrates the fracture, figure 24.5, and also reveals the signs of osteopenia leading to the diagnosis of osteoporosis. Once osteopenia is noted, other causes of metabolic bone disease must be ruled out, including hypothyroidism, hyperparathyroidism, osteomalacia, testicular failure, malignancies, and so on. Histologically, a thinning of cortical bone and a reduction in the number and size of the trabeculae of cancellous bone occurs. See figure 24.1. 30% or greater bone density loss must occur before such abnormalities can be noted on a radiographic film. Laboratories testing. Laboratories testing can detect other risk factors and can provide clues to treatment. Osteoporosis is not curable, but intervention can stop the progression of bone loss and prevent further morbidity. Secondary osteoporosis intervention begins with treatment of the underlying cause. Management of primary and secondary osteoporosis in the adult should include lifestyle measures to reduce bone loss such as a high calcium intake, smoking cessation, reducing alcohol intake, and physical activity and exercise. Besides eliminating factors such as chronic alcohol abuse and cigarette smoking, a key to prevention is developing as great a peak bone mass as possible through adequate calcium intake and regular exercise. Calcium is required for bone mineralization and also suppresses bone turnover, slowing the remodeling process. Fall prevention is an important intervention for anyone with low bone mass and high risk factors. Reports suggest that premenopausal women need more than 1,000 milligrams of calcium daily, and postmenopausal women need more than 1,500 milligrams daily. See Table 24.1. The average calcium intake of postmenopausal women is 400 to 500 mgd, well below the recommended levels. Vitamin D, 800 units D, is advocated to assist in maximal absorption of dietary calcium. 105 medications. Pharmacotherapy to reduce fracture risk in women with reduced BMD is initiated when the T-score is below 2.0 in the absence of risk factors or below 1.5 if other risk factors are present. 98. 105 T-score is not the only measure of fracture risk. A 70-year-old woman with a T-score of 2 is at greater immediate risk of fracture than a woman 50 years of age with the same T-score because of other variables common in the older age population that can increase fracture risk, for example, poor eyesight, reduced muscle mass, balance problems, or medications. Paying attention to individuals who are osteopenic, low bone mass but without the microarchitectural bone changes seen in osteoporosis, is important because there are increasing numbers of people who are osteopenic and who do experience bone fracture. 140 Despite the availability and favorable safety profile of bisphosphonates, many people are not receiving therapy, including men who have low BMD or who are at risk of fracture from osteoporosis. 15 Postmenopausal women need estrogen replacement with selective estrogen receptor modulators, SERMs, which maximize the beneficial effect of estrogen on bone and minimize or antagonize the deleterious effects on the breast and endometrium, or anti-resorptive agents, such as bisphosphonate, to help prevent bone loss. Although calcitonin is not approved for prevention, it is approved for treatment because it acts directly on osteoclasts, suppressing activity. 105 Bisphosphonates are a family of drugs that inhibit bone resorption and actually reverse bone loss. These drugs are currently being used in various bone conditions involving increased levels of bone resorption such as osteoporosis from a variety of clinical causes, glucocorticoid-induced bone loss, hypercalcemia of cancer, and Paget disease of bone. The use of bisphosphonates in reducing bone pain associated with cancer is described in Chapter 26. Researchers are evaluating 2 long-term effects of various treatment interventions. 1. The effect of each agent on BMD and 2. The effect of each agent on fracture development. For women in a state of estrogen deficiency, exercise or estrogen supplementation alone does not prevent bone loss, but exercise combined with estrogen causes a synergistic effect. 106 Criticism of studies using exercise alone include the non-specificity of the exercise to the targeted area being measured. For example, walking and lifting weights are not enough of a stimulus for the forearm. Further research is needed to clarify the role of specific loading exercises in exercise prescription for postmenopausal women. 6104 Estrogen and estrogen plus progestogen supplementation has been found to reduce the risk of fractures, but once discontinued, within 1 year fracture risk resumes at a level similar to that in women who have not received such therapy. 105 For this reason, the labeling of estrogens has been modified to state that they may be used to manage osteoporosis. The lack of efficacy of calcitonin to prevent bone loss during the first 5 years after menopause and the lack of prospective fracture reduction data for estrogen have resulted in these labeling restrictions. SERMs and bisphosphonates have been shown to increase BMD and decrease fracture risk. 105 For men, the addition of testosterone therapy for those individuals with normal gonadal function is inconclusive, but may be beneficial in improving bone mineral density for those with lowered testosterone levels. 787,158 Raloxifene, Evista, is the only SERM approved by the Food and Drug Administration, FDA, for the treatment and prevention of osteoporosis. It is the first compound with selective estrogen agonist activity in bone but with estrogen antagonist activity or no activity in reproductive tissues and breasts. Treatment. Osteoporosis is not curable, but intervention can stop the progression of bone loss and prevent furthermore. Other second-generation SERMs, bazodoxifene, lasofoxifene, oporia, and strontium ranelate, Protalus, remain under investigation. Raloxifene reduces the risk of positive estrogen receptor breast cancer, decreases total cholesterol and low-density lipoprotein, LDL, cholesterol, and increases high-density lipoprotein, HDL, cholesterol but does not increase the risk of endometrial cancer or cause spotting and bleeding. 45,105 After 4 years of treatment, raloxifene reduces the risk of first vertebral fracture by 50% with sustained efficacy in the continued reduction of fracture reduction in the 4th year. 84 Raloxifene treatment does not change the physiologic structure of bone quality and does not cause fibrosis, osteomalacia, or other toxic effects. 121 Or resorptive agents currently approved for treatment of osteoporosis, for example, bisphosphonates, SERMs, or nasal calcitonin, decrease bone resorption but cannot induce new bone formation. Consequently, their effects are limited. The use of agents that stimulate new bone formation, such as recombinant human PTH, rHPTH, teriparatide, is recognized as a single agent and in combination with anti-resorptive agents. 98,105 A once-a-year pharmacologic treatment with zoledronic acid, Zometa, has been reported from the Horizon pivotal fracture trials involving multiple investigators from several countries. Postmenopausal women with osteoporosis treated with a single infusion of intravenous zoledronic acid had a 70% reduced risk of vertebral fracture during a 3-year period and a 41% reduced risk of hip fracture. This treatment is most effective in preventing vertebral fractures in younger women with lower risk factors. The advantage of this drug is the increased compliance rate because of the convenience of a once-yearly infusion as opposed to a weekly or monthly dose regimen. It should be noted that higher rates of serious atrial fibrillation occurred in the zoledronic acid group. 10, 14, 61 Combined administration of hormone replacement therapy, HRT, and bisphosphonates appears to have a more pronounced effect in the appendicular skeleton than the axial skeleton, with greater increases of bone mass at the lumbar spine and hip than for either of the therapies alone. 51 The use of an ultra-low dose estrogen patch has been shown to improve bone density in animal and human trials. The skin patch contains a very small amount of estrogen with no progestin and has been used to increase bone density without harmful side effects in small groups of women. There is some evidence that the protective effects of ultra-low-dose estrogen therapy depends on a woman's endogenous estrogen levels before treatment. The optimal dose levels for this therapy have not yet bone defined. 38, 58, 70. An important research finding has been the discovery of osteoprotegerin, OPG, a protein belonging to the tumor necrosis factor receptor family. OPG occurs naturally in the body and plays a key role in the physiologic regulation of osteoclastic bone resorption. Animal studies have shown that OPG increases bone mass by reducing osteoclast production. Limited data suggest that OPG and PTH work together synergistically to improve bone mass and strength beyond what either can accomplish alone. The discovery of OPG has opened a new era in bone research by increasing the molecular knowledge available and providing new therapeutic targets in bone disease. 43, 73, 78. Exercise. Exactly how much benefit can be gained from given levels or types of exercise remains unclear, but the consensus is that regular exercise has a positive effect on bone mass levels. Weight-bearing exercises, against gravity, such as walking and jogging, stress the skeletal system and are associated with greater changes in bone remodeling and result in larger bone mass, although the effects on bone mass differ in premenopausal versus postmenopausal women. Exercises combined with bracing or other rehabilitative measures aimed at reducing the anterior translation of the cervicothoracic spine and thoracic hyperkyphosis may be beneficial in reducing the risk or occurrence of osteoporotic fractures. 69. Vibration. Whole body vibration, also known as oscillating plate therapy, is a new method of treatment being tested as a tool for the prevention and treatment of osteopenia, osteoporosis, and bone fractures. Vibrating plates that the size and shape of a bathroom scale have shown effectiveness in increasing BMD and balance. Vibratory exercise may be more effective than walking to improve both these measures. Researchers continue to investigate the physiologic mechanisms involved and to identify the most appropriate parameters to use that are both safe and effective. 3,174,759,172 surgery. Because of the challenges of reconstruction of osteoporotic bone, open surgical management is reserved only for those rare cases that involve neurologic deficits or an unstable spine. 138 new minimally invasive procedures for management of acute vertebral fractures, vertebroplasty, and kyphoplasty. Treatment. The optimal dose levels for this therapy have not yet been defined. Which involve the injection of bone cement into the fractured vertebra, are discussed in Chapter 27. Prognosis. Osteoporosis, once thought to be a natural part of aging among women, is no longer considered age or gender dependent. Although osteoporosis is one of the greatest deterrents to women's health and accounts for significant morbidity and mortality, it is largely preventable because of the remarkable progress in the scientific understanding of its causes, diagnosis, and treatment. Even so, at the present time, 24% of women over the age of 50 years die from complications, for example, pneumonia, infections, and fracture emboli, in the first year after an osteoporotic-associated hip fracture. 98. As mentioned, a first fracture has a 2 to 4-fold increased risk of a second fracture with associated morbidity and mortality. The exact mechanism for increased fracture-associated mortality is unclear. It could be secondary to the underlying poor health of the affected individual, for example, poor nutrition, dementia, weakness, deconditioning, low bone density. 0.11 Medical treatment for osteoporosis has been shown to decrease the incidence of vertebral fractures by 40% to 60% after just 1 year of treatment. The occurrence of a single vertebral fracture substantially increases the likelihood of future fractures and progressive kyphotic deformity. 105. Even so, only 50% of women with vertebral compression fractures diagnosed incidentally with chest radiographs are started on any pharmacologic treatment. Only 40% of patients admitted with an osteoporotic hip fracture are referred for osteoporosis treatment, and only 6.2% receive osteoporosis treatment at the time of discharge. 60. 93 vertebral fractures are accompanied by increased mortality, with the relative risk of death after such a fracture being almost 9 times higher than the person without osteoporosis-associated vertebral fracture. 48,153 Low bone density at the hip is a strong and independent predictor of all cause and cardiovascular mortality in older men aged 65 years and older. 159 adverse side effects of long-term use of bisphosphonates have been reported that affect the GI system and included esophagitis, heartburn, abdominal pain, and diarrhea. Intravenous bisphosphonates can cause transient acute phase reactions with fever, myalgia, and flu-like symptoms. Osteonecrosis of the jaw has also been raised as a possible concern, most often with intravenous administration of bisphosphonates used to manage hypercalcemia associated with metastatic disease. Adherence to osteoporosis medications is relatively poor, with up to 30% of individuals suspending their treatment within 6 to 12 months of initiating therapy. Poor adherence is usually attributed to drug-induced adverse effects and results in increased risk of fracture and hospitalization. 110 Some women have discontinued pharmacologic treatment early because of bothersome side effects or from a misinterpretation of their BMD test results. 156 Special implications for the therapist. 24 Osteoporosis. Physical therapists may initially see someone with osteoporosis for problems that are secondary to this condition. Medical diagnosis and impairments can include cervical and thoracic pain from hyperkyphotic postures, vertebral fractures and degenerative disc disease, and falls from balance disorders. There may be additional activity limitations as well. All older adults need to be asked about their history of bone health and for known results of prior tests for bone mineral densities such as with a DEXA scan. These individuals may have been given their DEXA scan T-scores but may not have been assessed for risk of fracture using the newer FRAX assessments. Therapists should keep in mind that the diagnosis of osteoporosis has implications for the quality of movement, independence with daily activities, and risks for other disease conditions. Treatment programs for osteoporosis and osteoporosis-related conditions should be designed to address the common impairments found with these individuals and to prevent problems associated with falls and vertebral fractures. The goals for a treatment program need to be set at 3 to 6 months in length in order to see key changes in impairments and activities limitations. The treatment program should be designed to be continued by the patient-client independently for up to a year before a re-evaluation will be needed. Plan of care and interventions. Intervention begins with the identification of people at risk or who have been identified as osteoporotic but who have not received any education, training, or rehabilitation. Management of fractures and special implications for the therapist regarding fractures are discussed in Chapter 27. Many questions, issues, and concerns about future intervention and exercise parameters for osteoporosis remain unsolved at this time. Therapists should be aware of the various aspects of the osteoporosis and the overall medical and rehabilitation management of this condition. The connection between osteoporosis, postural changes, see postural assessment below, and movement must be appreciated by the therapist when formulating a plan of care. The role of the physical therapist in maximizing these goals is an important key to the success of these individuals. Clients must be educated about the importance of each aspect of the intervention program. For example, calcium alone, without exercise and adequate vitamin D, cannot prevent osteoporosis regardless of how much calcium is taken. Since we do not store up calcium as adults, supplementation only provides necessary calcium for as long as the supplements are taken. Importance of compliance when evaluating the effect of medical treatment or rehabilitation intervention. The outcome is only as good as the individual's compliance. A long-term commitment to any program is required. No immediate benefit may be perceived, especially when the individual is asymptomatic and has an overall lack of appreciation of the seriousness of the problem. Older adults experiencing cognitive decline and forgetfulness are also at risk for non-compliance. Management goals are centered on stabilizing or increasing bone mass, preventing fractures, maximizing physical performance and function, improving quality of life, and managing symptoms, especially in the presence of pain from fractures and deformity. 68-99 Screening assessment. The clinical implications of osteoporosis are varied, numerous, and significant. Considering the prevalence of primary osteoporosis and the diseases and medications with which osteoporosis can be associated, therapists will encounter this disease often. Anyone who has had a first osteoporotic-induced or low trauma fracture should be screened for weakness, especially quadriceps muscle weakness, and level of decreased physical activity, both are risk factors for death following this type of fracture. 11 The Osteoporosis Assessment Questionnaire and the Health-Related Quality of Life, HAQOL, can be used to assess the functional levels of individuals with osteoporosis. 76,117,157 postural assessment. Older adults should be routinely assessed for postural changes secondary to osteoporosis. The assessment of posture in supine and prone position may reveal problems not seen in standing, including tightness in pectoral and hip flexor muscles and weaknesses in the extensor muscles of the trunk and hips. A hyperkyphotic posture may be associated with movement dysfunction in the lower and upper extremities as well as limiting pulmonary function. Older individuals with hyperkyphosis may choose to limit their walking patterns and activities to prevent falling episodes and may not report this as problem or concern. The assessment of balance, functional activities, and walking speed may show deficits compared to age-matched norms. Therapists should be aware of the symptoms and signs associated with osteoporosis, since they may be in a position to refer a client to a physician for examination based on a change in the person's status, especially in the presence of significant risk factors. For example, a 65-year-old woman being treated for a rotator cuff disorder may report the onset of sharp mid-thoracic pain associated with sneezing since her last visit, but she now notes a constant, dull ache in the area. In addition, the client and therapist note an increase in the thoracic kyphosis. Communication with the physician regarding these clinical changes is warranted because of the concern about a possible fracture. The therapist should also be aware of the potential side effects common to osteoporosis medications. For example, calcium can cause constipation, quercetin may be accompanied by nausea and flushing, raloxifene may cause leg cramps, and the bisphosphonates are associated with GI intolerance and or esophagitis. Side effects of estrogen replacement therapy are listed in box 24.4. Numerous medications, for example, antihypertensives, sedatives, psychotropics, diuretics, narcotics, antidepressants, and antipsychotics, can contribute to a loss of balance and falls. A balance and fall assessment and falls prevention program is essential for anyone at risk for osteoporosis, anyone with diagnosed osteoporosis, or anyone with a past history of fragility fractures associated with osteoporosis. Exercise and osteoporosis therapists have an important role in the promotion of exercise as a preventive measure for osteoporosis. As mentioned, exercise is considered to have an important role in maintaining and possibly increasing peak bone mass. Exercise should be started early in life to increase peak bone mass and should be maintained across the lifespan to minimize the risks of osteoporosis. Exercise not only improves musculoskeletal health but also reduces the chronic pain syndrome and decreases depression associated with osteoporosis. 143 The American College of Sports Medicine has published a position stand on physical activity and bone health, including suggestions for exercise prescription for children and adolescents and for adults. Table 24.3.72 Some evidence that exercise-induced gains in bone mass in children are maintained into adulthood suggests that physical activity habits during childhood may have long-lasting benefits on bone health. Quantitative dose-response studies are still lacking in this area, so the guidelines offered are suggestions based on best evidence. Exercise for adults. The results of numerous studies of exercise and bone health as they are presented here represent 4 different exercise-related issues. 1. Building bone mass. 2. Slowing the decline of BMD. 3. Preventing fracture. And 4. Maintaining muscle mass and strength. An excellent summary of many studies of specific types of exercise in differing populations is available. 104 Although the effect of exercise on slowing the decline of BMD later in life is modest, studies have shown that the factors associated with falls such as balance, strength, and mobility are improved with moderate level exercise program. 65 The level of exercise must be maintained because the benefits are lost if exercise is discontinued. A physical therapist understands the musculoskeletal system and the underlying pathologies and comorbidities and can implement an effective intervention plan that takes these variables into consideration. Weighted exercise combined with calcium citrate supplementation has been shown in the bone estrogen strength training BEST study to increase bone density even in women who did not take HRT. Exercises, such as leg presses, seated rows, wall squats, and back extensions and latissimus pull-downs, improve bone in the wrists, hip, and spine by 1% to 2% even in women who did not take a hormone replacement. 24 type of exercise. Exercises to build bone density must be directed at the muscles supporting or attached to the affected bone. Both aerobic and resistance training exercise can provide weight-bearing stimulus to bone, but research indicates the resistance training has a more profound site-specific effect, directed at the areas that demonstrate bone loss, than aerobic exercise. 89,104,143 men cross-sectional and longitudinal studies have shown a direct, positive relationship between the effects of resistance training and bone density. 67, 85, 104, 169. On the other hand, aerobics, yoga, Pilates, and Tai Chi Chuan are more likely to increase muscle strength and help maintain coordination and balance, which help prevent loss of balance and provide protection during loss of balance or falls. 982,114. 149 more studies are available now regarding the effects of Tai-Chi on BMD, especially in postmenopausal women. Limited evidence suggests that Tai Chi may be an effective, safe, and practical intervention for maintaining BMD in postmenopausal women. 97,164,165 for the more active adult with osteoporosis. Activity assessment is also important. For those with vertebral osteoporosis or previous history of vertebral fractures, activities such as golfing, bowling, biking, rowing, sit-ups, or other exercise with a major component of spinal flexion, side bending, or spinal rotation should be excluded. Swimming is an excellent physical activity, especially for those individuals with arthritis or other joint involvement, but without a weight-bearing component. It is not beneficial to offset the complications of osteoporosis, nor does it build bone density. Intervention modalities may include therapeutic exercise, resistance bands, foam rolls or balance balls, electrotherapy modalities, spinal orthosis or corsets, soft tissue mobilization, and so on. During an acute symptomatic episode, local modalities are often used to control pain and improve movement and function. Using the Osteoporosis Disability Index can help document improvements and positive outcomes. 109 exercise prescription. Similar to muscle strengthening, the intensity of the challenge to the bone must be gradually increased. Principle of overload, and must exceed the level of challenge to which the bone has already adapted. The program must be continued or these changes will reverse. Overall, it appears that high load, short duration stimulus causes a minimal effective strain that induces bone growth. The remodeling process seems to respond best to changes in the distribution of strain, suggesting that exercise should be diverse, involve different loading situations, and involve strains imposed at fast rates, with few repetitions needed to obtain the maximal osteogenic effect. 104 site-specific extensor isometric stabilization exercises are key to the prescriptive exercise program but must be augmented by a total program of reducing risks, implementing postural correction and scapular stabilization, and improving weight-bearing patterns, strength, balance, and flexibility. The parameters of duration, frequency, and intensity, dosage, and other concepts of prescriptive exercise, box 24.5, need to be better defined and further investigated with randomized control studies. Therapists may find comprehensive information provided for our profession in regards to safety in movement for persons with low bone mass, osteopenia, and skeletal fragility, osteoporosis, through the materials and seminars offered by Sarah Meeks, PT. See www.sarahmeekspt.com. To minimize the risk of development of musculoskeletal repetitive overuse syndromes, education regarding the proper use of exercise equipment, proper body mechanics, variety in the exercise program, and awareness of warning signs of overuse injuries is essential. Exercising excessively can have detrimental effects. For example, women who exercise to the point of amenorrhea may lose bone rapidly, enhancing the risk of developing osteoporosis. 2,839,167 Aquatic therapy. See also General Guidelines for Aquatic Physical Therapy, Appendix B. Although swimmers have been shown to have higher mineral densities than those of control groups, the protective effect of swimming as an effective exercise against osteoporosis and subsequent fractures has not been demonstrated. Activities with substantial muscular involvement but without gravitational forces are associated with lower BMD than those with a weight-bearing component. 26,150. Although swimming and aquatic therapy are not weight weight-bearing activities and therefore are not preventive, they still help maintain range of motion, build strength, and increase cardiovascular fitness with minimal stress on bones and joints. Walking in the water against the resistive force of the water is a better alternative for those individuals participating in an aquatic exercise program. One study done to assess the effects of a water-based exercise and self-management program on balance, fear of falling, and quality of life in community dwelling women 65 years of age or older with a diagnosis of osteopenia or osteoporosis indicated that water-based therapy improves dynamic standing balance. 29 There was significant improvement in the physical functioning, vitality, social functioning, and mental health for the intervention group. The improvements in these psychosocial domains could have resulted from the benefits of increased activity, effects of the water, or the group interaction and socialization. 29 Fracture prevention therapists also have a role in the prevention of the most serious complication associated with osteoporosis, fracture. A prescriptive exercise program designed to improve flexibility, balance, and strength may help prevent osteoporosis, fractures, and falls. Based on our understanding now that there is a link between depression and osteoporosis, the therapist's intervention for people who are experiencing major depression should include fracture prevention. 133,174. See Depression in Chapter 3. A physical therapist can design an exercise program that can help increase bone density with proper strengthening and weight-bearing exercises, lessen stress on bones through improved balance, posture, and body mechanics, and identify potential hazards in the home or workplace environment that can lead to fractures in those with osteoporosis. Choosing the appropriate gait-assisted device and teaching the person how to use the walker, cane, and other aids properly could also prevent injury. Educating the individual and family regarding home ambulatory hazards, such as throw rugs, faulty footwear, is important for fall prevention. See extensive discussion of this topic in Fracture in Chapter 27. Quality of life. Because of the costs involved in treating osteoporosis and the potential benefits offered by exercise, a need exists to expand the evaluation of exercise programs to include other relevant endpoints, such as quality of life and general fitness and well-being. Among older women who have exceeded average life expectancy, quality of life is profoundly threatened by falls and hip fractures. Any loss of ability to live independently in the community has a considerable detrimental effect on their quality of life. In a landmark study, the majority of women 75 years and older reported being willing to trade almost their entire life expectancy to avoid a hip fracture that would result in being admitted to a long-term care facility. In short, 80% said they would rather be dead. 126 The female athlete and osteoporosis. See further discussion in Female Athlete Triad, Chapter 3. The therapist working with female athletes must be aware of the documented decrease in bone density despite normal calcium intakes and regular exercise. A unique challenge exists with this population, the need to reduce bone stress while maintaining adequate muscular and aerobic conditioning in female athletes who are amenorrheic. 101 The therapist can offer important client education. Since many athletes do not realize the long-term orthopedic consequences of menstruation cessation, in the presence of bone density decline, the therapist should identify and initiate alternative training regimes. Non-weight-bearing and minimal weight-bearing activities, such as aquatic therapy and cycling, will significantly decrease the forces acting on the bone while still maintaining the training effect. Pool running is a viable activity for maintenance of cardiovascular and muscular training that closely simulates the sport itself. 154 Most athletes do not seek physical therapy intervention until pain has developed after the occurrence of a stress reaction or fracture. The main objective of intervention at this point is to use physical agents for pain reduction combined with alternative non-weight-bearing therapies. A slow, careful progression back to normal training intensity and duration of weight-bearing should be instituted. Education of the client throughout the entire process for prevention of fracture recurrence is of utmost importance. 120 Precautions and considerations in people with known osteoporosis or those at high risk of having the disease. Caution should be taken with examination and treatment techniques. For example, using a posterior pressure technique at the thorax for provocation and mobility assessment with the client positioned prone will place significant stress on the rib cage, possibly resulting in a fracture. thoracic spine mobilizations. Using gentle mobilizations in a seated position has been used as part of successful rehabilitation program to attenuate thoracic kyphosis in elderly women with osteoporosis. Although it is important that provocation and mobility information be collected and joint dysfunction be treated to improve functional abilities, precautions must be taken, including using other techniques or altering the person's position. For example, side lying or sitting, so that the anterior thorax is not stabilized. 160 as with other metabolic bone diseases, delayed healing and poor retention of internal fixation devices after fracture can occur in clients with osteoporosis. Post-operatively, the response to rehabilitation may be slowed, and adjustments may have to be made in the program to protect the injured area as recovery takes place. Close communication with the physician is called for to ensure safety. BMD of the spine is correlated with the strength of spine extensors, so maintaining muscular strength of the spine muscles is important. 56 Reduction of back extension strength is correlated with increasing age and body mass index in both men and women. Although men have a greater loss than women with increasing age, in both genders, more loss of back extension strength than appendicular muscle strength occurs. 142 Flexion exercises are clearly contraindicated for anyone with osteoporosis. Anterior compressive forces associated with forward flexion of the spine can contribute to vertebral compression fractures. Posterior pelvic tilt and partial sit-ups, minimal abdominal crunches, lifting the head and upper torso only to the level of T6, do not appear to cause any anterior compressive force. 141 The inflammatory nature of rheumatic diseases may predispose people to osteoporosis as it interferes with normal bone metabolism. This is compounded by the inactivity related to pain, joint inflammation and discomfort, muscle weakness, fatigue, and functional impairment. Weight-bearing exercise, sometimes even that performed during normal daily activities, helps maintain bone mass, but these clients often have limited ability to exercise or even walk. In such cases, aquatic therapy may be the only viable alternative despite the limitations mentioned. The medical interventions for the prevention or management of osteoporosis also have implications for the therapists. Medication side effects may occur at any time and may warrant communication with the physician. Box 24.4 lists the side effects of estrogens. Estrogen therapy has been associated with blood clots, heart attack, stroke, and breast and endometrial cancer. To reduce the risk of endometrial carcinoma, estrogen is taken with a progestin. Clients with a history of these conditions are at greater risk of developing side effects. Nevertheless, HRT has an important role in reducing the rate of bone mass loss, although its role in reducing the risk of developing cardiovascular disease has come under question. See menopause and hormone replacement therapy in Chapter 20. A side effect of calcium supplements that warrants immediate communication with a physician is urinary dysfunction. Mild diarrhea or constipation or a chalky taste that does not resolve should be brought to a physician's attention.
Okay, wow. This is a long one. I probably should have done osteoporosis by itself. And then osteomalacia after, but anyway. Let's see. Let's go back to the PowerPoint. Okay. Uh-oh. We want to be slow today, don't we?
Exclusive videos, practice questions, and flashcards, and so much more. Try it free today.
Osteo refers to bones, and porosis means pores. So, osteoporosis is when there's a higher breakdown of bone in comparison to the formation of new bone, which results in porous bones, meaning a decrease in bone density to the point of potential fracture. Looking at a cross-section of a bone, there's a hard external layer known as the cortical bone, and a soft internal layer of spongy bone, or trabecular bone, that is composed of trabeculi. The trabeculi are like a framework of beams that give structural support to the spongy bone. The cortical bone, in turn, is made up of many functional, pipe-like units called osteons, which run through the length of the bone. In the center of these osteons, there are hollow spaces called haversian canals, which contain the blood supply and innervation for the bone cells. Around the haversian canals, there are concentric lamellae, which look a bit like tree rings. The lamellae have an organic part, which is mostly collagen, and an inorganic part called hydroxyapatite, which is mostly calcium phosphate. In between neighboring lamellae, there are spaces called lacunae, which contain bone cells called osteocytes. At first glance, bone may appear inert and unchanging, but it's actually a very dynamic tissue. In fact, spongy bone is replaced every 3 to 4 years, and compact bone is replaced every 10 years, in a process called bone remodeling, which has 2 steps. Bone resorption, when specialized cells called osteoclasts break down bone, and bone formation, which is when another type of cells called osteoblasts form new bone. Bone remodeling as a whole is highly dependent on serum calcium levels, which in turn are kept in the normal range by a balance between parathyroid hormone, or PTH, calcitonin, and vitamin D. Parathyroid hormone is produced by the parathyroid glands in response to low serum calcium, and it increases bone resorption to release calcium into the bloodstream. On the other hand, calcitonin is produced by the thyroid gland in response to high serum calcium, so it opposes the action of PTH, therefore promoting bone formation and decreasing bone resorption. Finally, vitamin D promotes calcium absorption in the gut, so it increases serum calcium, promoting bone formation and decreasing bone resorption. The balance between these regulatory factors results in a peak bone mass, usually by age 20 to 29, and this usually occurs earlier in females than in males. Factors that determine the peak bone mass are genetics. For example, people of African descent tend to have greater bone mass, and nutrition, meaning adequate vitamin D intake increases bone peak mass. Finally, strength training increases peak bone mass, as well as hormones like estrogens and androgens that inhibit bone resorption. Okay, now when osteoclasts break down bone faster than the osteoblasts can rebuild it, it results in the lowering of the bone mass and eventually in osteoporosis. If we zoom into a cross-section of an osteoporotic bone, it will show normal cells with normal mineralization, which differentiates it from osteomalacia, where there's a lack of mineralization. So with osteoporosis, abnormal findings include fewer trabeculi in the spongy bone and thinning of the cortical bone, as well as the widening of the haversian canals. These bone changes increase the risk of fracture, and they're known as fragility or pathologic fractures. Some bones, like the vertebrae, shoulder blades, and ribs, consist mainly of spongy bone, so they're in great risk of fragility fractures. Factors that accelerate bone mass loss and increase the risk of osteoporosis are low estrogen levels, like after menopause, and low serum calcium. Additional factors include alcohol consumption, smoking, drugs like glucocorticoids, which decrease calcium absorption from the gut through the antagonism of vitamin D, and drugs like heparin and L-thyroxine. Another factor is physical inactivity, as seen in astronauts in a zero-gravity environment where they just don't use their musculoskeletal system as hard as when they're on Earth. As a result, bone deposition decreases due to a lack of stress, while resorption increases. There are also diseases that can cause osteoporosis, like Turner syndrome, hyperprolactinemia, Klinefelter syndrome, Cushing syndrome, and diabetes mellitus. Now, the 2 most common types of osteoporosis are postmenopausal osteoporosis and senile osteoporosis. In postmenopausal osteoporosis, decreased estrogen levels lead to increased bone resorption. With senile osteoporosis, on the other hand, it's believed that osteoblasts just gradually lose the ability to form bone, while the osteoclasts keep doing their thing unabated. So, bone resorption usually overtakes bone formation around the 8th decade of life. People with osteoporosis don't usually have symptoms until a fracture occurs. The most common type of fractures are vertebral fractures, also known as compression fractures, and that occurs when one or more bones in the spine weaken and shatter. Vertebral fractures cause back pain, height loss, and a hunched posture. Femoral neck fractures and distal radius fractures can also occur, and they're often associated with postmenopausal osteoporosis. Osteoporosis is usually diagnosed with a dual-energy X-ray absorptiometry, or DEXA scan, which tests for bone density. The test compares an individual's bone density to that of a normal adult, which yields the result, or the T-score. A T-score less than or equal to negative 2.5 is diagnostic of osteoporosis. Treatment for osteoporosis usually relies on bisphosphonate drugs like alendronate and risendronate. If osteoporosis is really advanced, teriparatide, a recombinant parathyroid hormone, can be used. Now, even though parathyroid hormone stimulates bone resorption, it's been found that intermittent injections with teriparatide activates osteoblasts more than osteoclasts, therefore increasing bone formation. Interestingly, a thiazide diuretic like hydrochlorothiazide can be used to treat osteoporosis as well. Hydrochlorothiazide boosts calcium retention in the kidney and directly stimulates osteoblast differentiation, therefore decreasing mineral bone loss. Finally, medications like denosumab, which is a monoclonal antibody that inhibits osteoclasts, and raloxifene, which is a selective estrogen receptor modulator, can be used for postmenopausal osteoporosis. Alright, as a quick recap, osteoporosis refers to decreased bone density on account of increased bone resorption compared to bone formation. In osteoporosis, there is thinning of the cortical bone, widening of the Haversian canals, and a decrease in the number of trabeculi in the spongy bone. There are two common types of osteoporosis. These are senile osteoporosis and postmenopausal osteoporosis. The most common type of fracture in osteoporosis is a vertebral compression fracture. Diagnosis is done with the dual energy X-ray absorptiometry, or DEXA scan, where a T-score equal to or less than negative 2.5 equals osteoporosis. First-line treatment relies on bisphosphonate drugs like alendronate and risendronate.
Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards. Thanks for watching. If you're interested in
Osteoporosis. First-line treatment relies on bisphosphonate drugs like alendronate and risendronate.
Okay, and we are going to end it there. Osteoporosis and osteomalacia.